And a very good morning to everyone. I'm really indebted to the organizing committee, the scientific chair, for giving me an opportunity to represent my specialty and be amongst my own very dear to heart internal medicine colleagues. I'm an internist first and then rheumatologist, and this is what exactly I had been teaching my students, that if you really want to be a true internist, you should really become a rheumatologist, because we really deal with devastating diseases like multi-system diseases. So, Nabil, thank you for your kind introduction as well. I would just quickly go over, I have no conflict of interest as far as this presentation is concerned. Just an outline brief of my talk. I would be actually presenting two studies which were really practice-changing, which really helped us to come up with this real-world data on efficacy and tolerability of Tofacitanib in patients with RA, and then comparing this Tofacitanib with secukinumab, an IL-17 inhibitor in axial spondyloarthritis. I would just then be briefly talking about an update on the recent safety issues. I would start off with a patient whom everyone sitting in this room, I think they can relate to. So she's a 57-year female. She's a diabetic, hypertensive. She's morbidly obese. She has rheumatoid arthritis for almost 4 years. Her disease has been badly managed, badly controlled on conventional disease modifying, and she has been following up with our orthopedic colleagues. You people must be knowing that this is still happening when we are around 150 rheumatology professionals, healthcare professionals in this country, so not still able to reach out to all of these patients who have rheumatoid arthritis. And this lady has been started on Tofacitanib 5 milligram twice a day. She had not been screened for any occult infections. There had been no consideration given to her cardiovascular risk factors. And she was doing pretty well. Her disease activity score, which is DAS28, actually happens to be 3.7. She was happy. But the issue was not this. The niece, which happens to be a final year student in Central Park Medical College, where I teach, who actually had a rotation in rheumatology, she wanted to make sure that she's being treated as per the guidelines. So now just a brief on the journey of Tofacitanib in rheumatology. We are aware that this medicine actually got approved for rheumatoid arthritis in 2012, then for psoriatic arthritis, and then came polyarticular GI, then ankylosing spondylitis, and then in September 2021, we had that study which I'm going to talk about, which actually came with this FDA box warning. I'm not going to call it black box, which actually at times it is referred to, but this is not a right moment, I believe, for the launch of this medicine in Pakistan. This was October 2021, when we actually had first generic of Tofacitanib available in Pakistan. So I'm going to just quickly go over this study, which was published in 2022 in New England Journal of Medicine, which was really a practice-changing study at that time. So this was the data which was mandated by FDA, the company, the Pfizer, who actually launched Tofacitanib in 2012, because there was risks seen of thromboembolic events and cardiovascular events in patients who were receiving 10 milligram twice a day dose of Tofacitanib in clinical trials. So they mandated them to have a post-marketing oral surveillance study. This was a phase 4 study. So there were 3 groups in this study. One was receiving Tofacitanib 5 milligram, one 10 milligram twice a day, and these were the patients who were on TNF inhibitors. These RA patients, they were not like a usual RA routine care patients. They were all 50 years and above, and they were having at least one cardiovascular risk factor. They were followed for a median of 4 years, and it was found that the hazard ratio for the major adverse cardiovascular event, which I'm going to call from now MACE, was 1.24, and for the malignancy, excluding non-melanoma cancer, was around 1.47. And this was in 5 milligram. The 10 milligram, the group actually, when they saw that there were increased prevalence of thromboembolic events in that group, so they were actually, this group was abandoned, and they were all then shifted to 5 milligram. The another study which came same year in 2022 from this oral surveillance trial was the risk of serious infections in these patients. And again, it was dose dependent. In 5 milligram, it was just a hazard ratio was 1.17. And in patients who were receiving 10 milligram, which is the dose generally which is approved for ulcerative colitis and not for rheumatoid arthritis, the hazard ratio was 1.4 with this CI intervals. This was seen in post hoc analysis that majority of the patients who actually had these infections, they were elderly. So they were more than 65. It was also seen that they were the ones who were on concomitant oral corticosteroids. They were the ones who had a very bad active disease. Pre-existing lung disease was also considered one of the risk factors along with the baseline opioid use. So what to do in such situation? So either just try to digest this. This was what rheumatology community at that time was trying to do, or start some real, like collecting data prospectively in the real world. So this was what exactly we thought. And this was the consortium of 4 sites which actually got together under the umbrella of Arthritis Care Foundation. And I'm glad that Professor Nighat, who is chairing this session, is the trustee and the founder of this foundation. And I am also part of it in a humble capacity. So this is the real world data. So on rheumatoid arthritis patient, as of today, patients who have been enrolled are like 343. These are the patients who are all fulfilling the ACR-EULAR criteria, which is 2010 criteria, the latest one as of today. And these are the ones who had a disease activity score of 3.2, which is like low disease activity cutoff, and they were more than 3.2 having. And we were looking at the primary outcome was proportion of patients who had achieved the low disease activity target at 3, 6, and 12 months period, as per the cutoffs of DAS28 score. These are the baseline characteristics of our patients. You can see over here that they are relatively younger. In RA cohorts, generally the mean age is 50 and above, but this is a relatively younger cohort. Considering this, that probably we were not starting patients on Tofacitanib who were 65 and above, or even in patients who are in early 60s, predominantly 80 as generally the cohorts are like. And you can also see that the comorbidities like diabetes, hypertension, were also low as compared to the RA cohorts. A study which was done by Hina, who is sitting here, my spouse, as part of her MPhil Public Health on cardiovascular risk factors a couple of years back, showed that diabetes and hypertension was found to be in around 24% and 37% respectively in RA cohorts. And then to talk about latent infections. We all worry with immunosuppressants that these patients can develop reactivation of tuberculosis. And in our cohort, 1 in 5, 20.2% actually had positive IGRA test. And Hep B was positive in 5%, Hep C in 9.7%. They were all PCR negative, and they were started on Tofacitanib. And those who were screened for almost everyone, we actually had a clinical audit as well, which is an abstract which is just submitted this week for the APLA 2024, which is going to be in Singapore, and hopefully I would be presenting that there as well. So was that we had Hep B core antibody positivity rate of 14.7%. They were the patients who are at risk, especially when we talk about rituximab. So there is a risk of fulminant hepatic failure in these patients, but not with Tofacitanib. But the guidelines say that we have to treat patients who are actually on rituximab. So these were the baseline characteristics: the tender joint count, swollen joint count, the patient VAS, their ESR, DAS28 score. And then if you follow them over 3, 6 months, and 12 months, you can see that there was significant reduction in terms of all these composite measures of disease activity. And this score is one which we use in our clinical practice as well as in clinical trials. So the pattern of concomitant DMARDs in our 343 patients, methotrexate was the commonest in more than half, and then was leflunomide. And monotherapy, Tofacitanib, was also used in 8% of the patients. And these were the outcomes which we had. So this was at 3 months, around 47.6% of the patients, 50.9% at 6, and at 12 months, 64% of the patients actually had achieved a target of less than or equal to 3.2 disease activity score on 28 joint counts, which was like every 2 out of 3 patients actually had achieved the target, which is a great in real-world situation. So these were the adverse events from our registry. So 30% of the patients at least had one adverse event, and the commonest was the upper respiratory tract infections. The second commonest was the transaminitis, and the third commonest was pneumonia requiring hospitalization in around 3.3% of the patients, and there were around 4 patients in our cohort who actually got herpes zoster as well. Because the median follow-up is just 16.5 months, it is too early to conclude data on the major adverse cardiovascular events, but we are following these patients. But they were like 1.1% of the patients who were withdrawn from Tofacitanib because of the suspected acute coronary syndrome. The patients' adherence to the medication, what we call retention rate, was very high. It was around 85%. Only 14.4% of the patients actually had to be withdrawn from Tofacitanib in our cohort. And majority of these, there were just 6.7% actually non-response, and very minority 4.4 was actually because of adverse event. And very few patients actually had a loss to follow-up. And I believe this is because of the improved access to this medication, which we had been able to have because of a funding which we got from Arthritis Care Foundation, because the majority of these patients, either they are less privileged or middle class, they can't afford medications which cost a lot. And when we compared our results with the study which was published last year in Armed Forces Journal on short-term efficacy of tocilizumab, so comparing tocilizumab with Tofacitanib, so we found that Tofacitanib really did well as compared to tocilizumab. Around 50% of the patients achieving the target. And this is at actually 6 months. We compared the results at the 6 month, and then adverse event was relatively lower in patients with Tofacitanib. And when we looked at the discontinuation rate in tocilizumab, it was like 1 in every 4 actually discontinued treatment at 6 months. Now quickly moving to an abstract which I'm very proud to share that one of our fellows presented as an oral presentation in Chiang Mai APLAR Congress last year in December. This is comparison of efficacy and tolerability of Tofacitanib and secukinumab in patients with axSpA. This is what exactly a score which we do ASTAS CRP, and these are the cutoffs. And we were looking at the relative efficacy of and the safety of Tofacitanib with IL-17 inhibitor, secukinumab, in terms of achieving ASTAS CRP response rates at 24 weeks. This was a retrospective study. The patients who were enrolled, they were fulfilling the ASAS criteria for axSpA, which is a new name actually for ankylosing spondylitis. The EMR review was done, and there were around 58 patients who were found to be on Tofacitanib and 40 secukinumab during the study period. And the SSCRP and the best eye scores and the baseline 3 months and at 6 months they were retrieved from the data. This was the baseline characteristics, and you can see that patients who were on secukinumab, they have a relatively longer disease duration as compared to patients with Tofacitanib. Otherwise, they were comparable. Looking at the remission rates in Tofacitanib group were much higher as compared to secukinumab. This is a stacked bar diagram, and in blue this is the Tofacitanib, and the low disease activity again was achieved, and the combined low disease and remission was achieved in around 80% of these patients, which were very reassuring results, because this disease which requires treatment with anti-TNF before and secukinumab, which are very costly treatment as compared to Tofacitanib. And these were the adverse events which were relatively more in patients with Tofacitanib but didn't reach any significance. Now quickly moving to the last part of my presentation. So this is a STAR RA study. This is a cohort. This was just after the results of the oral surveillance trial. This study after 6 months came up, which is data which was from the Medicare, that there were around 1 lakh patients who have been on rheumatoid arthritis patients who were included in this study. Out of these, around 12% were on Tofacitanib, which was like 12,000 patients. And when they really looked at the real world cohort, so they found that the hazard ratio for major adverse cardiovascular events for RA patients was only 1.01. And when they looked at the duplicated RCT cohort, what they did was that they exactly duplicated in their cohort patients who were, they segregated them and into patients who were having 50 years and above and who had one cardiovascular risk factor, and then they found that the hazard ratio went up to 1.24, which was almost same as seen in the oral surveillance. But this was again not statistically significant. So, but still the warning is there, and we know that there are real risks posed to these patients. So now coming back to my index patient, so how would I like to treat this lady now? So, and most of the physicians sitting here, so would they really like her to be on Tofacitanib? So this is something which actually, an agenda which is that the jury is still out on it. She's 57, but one thing I would really like to share over here, her HbA1c level was 7.5, which was not optimal. Her blood pressure control was not optimal. Her BMI was, she was morbidly obese. So what I did for her was that I withhold her Tofacitanib. I sent her IGRA. I sent screening for all these occult infections, and I updated her vaccinations, which were never done before. And I counseled her about CV risk factors and possible switching to another biologic. And I also emphasized on optimizing the control of diabetes, hypertension, and addressing obesity and dyslipidemia. So this is what we can achieve actually only when we as community, rheumatology, internal medicine, endocrines, we all come together and really start managing patients, keeping this goal in mind, that our goal is to improve outcome of our patients, not only the outcome in terms of achieving remission in rheumatoid arthritis, but also their cardiovascular outcomes. We have found that Tofacitanib is efficacious and well tolerated in our patients, and we have found that we still need to have a long-term safety data as far as cardiovascular events are concerned. And I'm really happy to take questions at the end of the session, and thank you again.